Transposition of the Great Arteries by Ryan, Kendall, and Evan. So our patient profile, we're going to name this baby L. He is 2 days old, male, gestational age is 39 weeks, birth weight is 3.4 kilograms, delivery was vaginal and uncomplicated. APGAR scores were 7 at 1 minute and 8 at 5 minutes. So within 30 minutes of birth, the infant developed central cyanosis and tachypnea. Initial pulse ox on Ramirez showed 68%. Baby was placed on 100% blow-by, and saturations only increased to 72%. No significant improvement was seen with CPAP at 5 and 100%. And due to persistent hypoxemia refractory to oxygen therapy, congenital heart disease was suspected. The infant was transferred to the NICU and they did more testing there. So the physical exam that the doctors performed revealed that the baby is cyanotic, tachypnic, and mildly distressed. You have all of your vital signs here with your heart rate at 168, rate of 70, blood pressure 68/40. SpO2 is 72% on 100%. Temp is 36.8. So the cardiac exam showed that there was a loud single S2 heart sound, but there was no significant murmur. Respiratory exam showed clear bilateral breath sounds, mild intercostal retractions. Obviously, you're going to have those retractions when you're 72%, 100%. So this baby's really gasping at this point. Not gasping, but they're having some respiratory issues, and it's starting to build. So the skin, central cyanosis, lips and nail beds are blue, which is indicative of hypoxemia. Belly was soft with no enlarged liver, and the extremities were warm, and they had good capillary refill. So we pulled an ABG off of this baby, cap gas, on 100% with CPAP of 5. The results are combined acidosis with hypoxemia. So chest x-ray was ordered. They wanted to see if there was any issues with the lungs, even though they were clear bilaterally, and to see what the heart looked like. So upon getting the chest x-ray back, there was mild cardiomegaly with an egg on a string appearance, which is the classic sign of transposition. The lung markings were normal, so there was no issues there. And then the echocardiogram was performed, and it revealed the dextrotransposition of the great arteries with intact ventricular septum. There was patent foramen ovale with minimal shunting, so that was closing up as it normally does. And the small patent ductus arteriosus with limited mixing, normal ventricular friction. So everything else was working fine. It was just that there was the transposition, and so the doctors had to then discuss what was next. So here's a picture of what transposition of the great vessels look like. So technically what this would be is instead of the right ventricle going into the pulmonary arteries, it goes into the aorta, and the left ventricle, instead of going into the aorta, goes into the pulmonary arteries. So there is blood mixing, and the blood that is supposed to go into the body is mixed instead of oxygenated. So this is where you're going to get that central cyanosis.
Here you can see the normal heart. As you can see, the aorta has the oxygenated blood, pulmonary arteries have the deoxygenated blood. And then in the transposition of the great arteries or vessels, we have the aorta, which is actually carrying deoxygenated blood, and then the pulmonary artery, which is carrying the oxygenated blood. So they're just swapped, and that's kind of the pathophysiology of it. I know we learned about it last semester, so we know a little bit about it. And some of the management, so it's a lot of surgical corrections. as needed, but the baby actually rarely survives the first year of life. And this surgery has to happen within a week of this of the infant being alive. And I kind of saw that the most common procedure was the arterial switch procedure, or they can do something called the palliation with a balloon atrial septostomy, which I watched a video and it was pretty crazy. And then some of the other surgical management revolves around you want to adequately oxygenate the patient, and you want to administer prostaglandins, which we kind of learned about last semester, to keep some of that stuff open. And what's kind of difficult is once this baby's born, they need to be hemodynamically stable before the surgery is initiated, which I know can be pretty difficult because they're already in pretty critical condition. So I kind of read that that's a difficult thing to achieve. And with physiologic repair, CHF can actually be more common like later as life goes on, and they can actually develop it. So yeah, congested heart failure is definitely a problem that can occur later in life too, and earlier in life. And kind of like I said, the surgery needs to be performed pretty quickly within the first week of life. And post-operative complications are super common in these babies, kind of like what I said, like congestive heart failure can be later developed and progress throughout life. So it's not an ideal situation at all. And then some of the ventilator settings. So we're going back to the volume control SIMV with pressure support, which this mode, it kind of took me a little while to like re-understand it, but it wasn't that bad. But basically this is just, you want to ensure general ventilation to avoid increasing the PVR, pulmonary vascular resistance. And this is with pressure support as well. And you want to aim for a tidal volume of like 8 to 10 mils per kilo. And for example, this patient on 30 mils, that's their 8 mils per kilo. A PEEP of 5 to 7, which can help with oxygenation, because we do want to keep these patients heavily oxygenated. And we want to aim for a pH of 7.35 to 7.45, which is the same with adults, and that SaO2 greater than 95%, which kind of just goes the arterial oxygenation wanting to be higher in these patients. And after surgery, the patients may be extubated. They can be extubated pretty quickly if their hemodynamics and if they're stable.
Okay, so now that we've got our infant stabilized on the ventilator with their ventilator settings, now we're gonna have to do some sort of cardiac intervention. These infants have to do surgery within the first 1 to 2 weeks in order to prove their cardiac function, because as we kind of explained earlier, they aren't getting as good of oxygen-rich blood flow because of that switch of the aorta and pulmonary artery. And so for this infant, we can manage them in just a couple of different ways. So first you can do medication, and that can include, IV prostaglandins, just to help keep that ductus arterius open, to allow some of that oxygen-rich blood flow to happen. And then we could also do cardiac catheterization. That's also just another helpful way before surgery to allow some more oxygen-rich blood flow to occur, especially since this infant is not getting as well as they should. But like I said, all of them will have to go through surgery, so our infant will have to go through surgery. Like I said, preferably within the first 1 to 2 weeks. And for our case study, we're doing the arterial switch procedure. And I have that laid out on the right here, but I'll describe it just so you can kind of understand what's going on. So first you'll disconnect you'll open the baby's chest, do a cardiopulmonary bypass. Then you'll just disconnect both the aorta, pulmonary arteries, and then also disconnect this, and then remove these coronary arteries. And then you'll reconnect them to what will be the baby's new aorta, so it'll be reconnected on this side over here. And then same thing, you'll switch that pulmonary artery on that other side. So now the aorta connects to the left ventricle, the pulmonary artery connects to the right ventricle. And then you close the baby's chest, and that's it for the procedure wise. So that's what we would do for our infant. And so post-op care is actually not too horrible. I say that, but so recovery time, we're looking at least another 2 weeks inside the hospital after the procedure, and during that time we can be, providing care. And then especially the medications is the big part. And so some medications we could have for our infant. I saw one, they were using aspirin to prevent clotting. Um, Other heart medications to control our infant's blood pressure and heart rate. That way we can manage it while they're in the hospital. Antibiotics to prevent infection for our infant, and then also really important pain relievers for our infant is what we would use to help them. But future outcomes. So for in our case, we're just dealing with the baby as is, but in general, most children can recover and live normal lives. However, they do need frequent monitoring, frequent checkups, visits, just to make sure they're doing well, because they are at increased risk for arrhythmias, leaky valves, narrowing of the arteries, and just other heart issues. So just monitoring them over time, but in general, they can live a normal life. So yeah, and then these are our references for our case study.